we had to put an IV in. And I had been an EMT and I was ready for a fight. And I got no fight at all. No wiggles, no squirms. And I literally turned, I said, I put in the IV, but this kid needs to go to head CT like yesterday. But he also did not fight the CT.
Hey there, I've got some exciting news to share, and I can't wait to tell you about it. So if you're multitasking, come back to me because this is something you won't want to miss. You may already be familiar with my 1-hour rapid response and rescue course, a quick dive into approaching critical patients. I'm thrilled to have received such positive feedback from nurses who found it valuable. But I'm not stopping there. I've been hard at work developing a more comprehensive, in-depth course. However, the more I work on it, the more I realize that I want to offer more than just another course to purchase. Reflecting on my years as an educator, what I truly cherish is the opportunity to interact with nurses in real time, breaking down complex concepts, mentoring, inspiring, coaching, and supporting nurses as they navigate the challenges of our profession. Teaching and empowering nurses is close to my heart. Over my 20 years in the field, I've amassed a wealth of clinical knowledge that I'm committed to sharing with nurses. But there's more to being a great nurse than just understanding pathophysiology. Through trial and error myself, I've gained other valuable skills related to leadership, advocacy, resilience, which I believe can be beneficial to all nurses. So here's the plan for 2024. I want to create a community of dedicated nurses who invest in themselves so that they can deliver exceptional patient care. This won't be just me recording myself for a podcast. I want to teach live, address your questions, and provide a platform for nurses to support one another. I'm calling it Rapid Response Academy, the heart and science of caring for the sick. Members will enjoy weekly live lessons, a community forum for questions, and personal interaction with me to better understand your needs and support you on your journey. This is uncharted territory, and I'm excited to explore it together. I'll be soft launching on December 1st to get to know the initial members. So those who sign up before December will receive a 25% discount and play a pivotal role in shaping the community from the ground up. The sign-up list opens on Friday, November 24th. If you're excited about more in-depth teaching, access to a supportive community of like-minded nurses, and the chance to be a part of our founding group, I'd love to have you on board. If you want to learn more about what I'm building, I put a link in the show notes for you. Now, let's get back to today's episode.
T did not move in the CT. The, oh my goodness, was already firing before we went to CT, and after it got worse, this child started to get more drowsy, and then we started to see like the telltale signs of basilar skull fractures.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. All right. Welcome back to the Rapid Response Room podcast. Today, I have an awesome guest to share with you. Casey is currently an assistant nurse manager in a mixed ICU. Casey, we're going to dive into a really interesting case of a patient who presented to your ER looking pretty stable, but turned out to have a pretty serious injury. But before we dive into the case, I would love to take a minute for you to share your nursing journey with my audience. Specifically, can we just start with your alphabet soup of a title?
Yes, so thank you. So I have a wonderful alphabet soup. So I started as a nurse in 2015. Now it's like becoming so long ago that I can't remember. I started in an actual like med-surg observation tele unit. And then my unit closed when I was an undergrad. And so my options were the ICU or the ED. And I picked the emergency department then and worked in the emergency department for a couple years, started working in the ICU, started doing critical care ground transport, and absolutely loved all of those things. And then in 2021, in the middle of the second wave of the pandemic, I decided it would be a great idea to start getting certified. And so
because you had nothing else going on in your life right now. It wasn't like you were busy working extra shifts at the hospital or anything.
Nothing like that. So I set out the goal to just be certified in the CTRN, which is a certified transport registered nurse. And that turned into me I just want to do that in CCRN. So, and that's the critical care registered nurse. And it turned into me taking the CTRN. And then I took the CTRN. And then I took certified emergency nurse, trauma registered nurse, and flight registered nurse all in April of that same year. And then I was like, okay, so the only one that's left for the high five club is the pediatric emergency nurse. And after I became an EMPC instructor, I was like, okay, let's do that. So after I passed the class and became an instructor, I took the CPEN, the pediatric emergency nurse, and passed that and became the 85th nurse ever to have all 5 of the BCEN certs.
That's awesome.
And then I was like, okay, well, I have all these ER certs and I don't have any critical care certifications. So I went on and did my cardiac medicine certification. And then I took some time, and after people called me a one-trick pony, she can't do this again. She took them all. Then this year, I obtained my 8th nursing certification, which is the certified registered neuroscience nurse.
Your 8th certification. Casey, that is so
too much.
That is so badass. It's so awesome. Okay, so I saw a picture of you online, and you had your name and your alphabet soup behind, and it's a whole freaking paragraph on your jacket.
The place that does the embroidery for my work jackets, they make fun of me because we're on 3 lines right now, and it's funny because it's I wear the jacket because it's for the moments that I need to stunt on people and be so here's critical care Casey, hello here. It's the one time that people are trying to test me, and I'm no, I have certs. But the rest of the time they're just covered.
I have proven myself. Yeah. I love it. Okay. So if your email signature, can you just list them all out? Prepare yourself, everyone.
Okay. So soon to be, in April next year, it'll become MSN. But right now my email signature is BSN, RN, CCRN with CMC connected because it's a subspecialty, CFRN, CTRN, CEN, TCRN, CPEN, CNRN, and then NRP because I'm a nationally registered paramedic.
Oh my gosh.
It's so long.
Casey, I love it so much. And I love that you can find the humor in it.
It's
so long.
It's ridiculous.
You don't take yourself too seriously?
No, not at all. And I think that's so funny. The thought of how ridiculous it is great. People see my email, they're this girl. So now I just get a kick out of it. It's hysterical. To finish my MSN program, I actually have to take 2 more certification tests. And I was if I get them, I'm not listing them in my email unless it's something educational.
The embroidery shop's going to be we're done. We're cutting you off.
We're done. 3 lines max. Yes.
I love it. I love it so much. I mean, everyone has their hobbies and vices, and yours just happens to be professional development. There's worse things you can be into.
That's it.
I love it. So question, do you feel having all of these certs has made you a better nurse?
I do. Actually, it's so weird. It's I can easily make fun of the certification, and I am truly an advocate of get certified in only the specialties you work in. So every certification I've worked in that area. And I think that people should be putting time into their certifications. You shouldn't just get random certs. But I will say that I learned so much while I was studying for certification, because there's always like, you have the background knowledge, but it's also weird because you don't like, I live in Maryland. We don't ever see snakes. We don't see like snakes that are on like the CEN. Like, and just like somebody who may be in another area of the world, well, really the world, but another area in the United States, they may not see like opiate addiction like we do in Baltimore. So it's kind of like an interesting like give and take. And you actually like learn a lot about how nurses everywhere do like emergency nursing and not just in your little like niche in your like one spot that you work in. So it was kind of interesting to learn and really interesting to find out that some of the things that like I had learned through the years were not the right thing.
Yeah, that's definitely eye-opening. When you're like, I've done this my whole career. This is how all the doctors that I work with do it. You're like, oh, this isn't evidence-based?
Yeah, and then you're like,
oh.
Or you think like you've learned like, oh, this is a late sign, this is an early sign. And then when you start like actually like pad to paper, like taking the time to like read up on things and study, you're finding that it's not. But I found that I was going outside of that and looking at like up-to-date and stat pearls and lip and cont and all these other resources like to find information to fill any gaps that I had in my knowledge.
Yeah. And it takes years to become an expert to be able to actually expose yourself to all the different random things that you might see as an ER nurse, as a flight nurse, as an ICU nurse. I mean, it takes years to get that. But when you're studying for these types of exams, when you study for 8 of them, you are accelerating that process of exposing yourself to all the things real fast because you have to know them all to pass the test. So, I mean, smart move on your part. You definitely launched yourself into being an expert much faster than the average nurse. I love that you did it in 2021 of all years. All right. So let's talk about this case. So can you just set the stage? Like, where were you working? How did the patient present? What made your nursing intuition say, something's going on besides what I see on the surface level here? Take it away.
So this happened when I was probably in my first year in the ER. I had been a floor nurse for a year and I was working down in the ER. I had just come off of orientation, maybe like 4 months before this. And we had a kid come in. I worked fast track in our emergency department. So like your low priority people, like a lot of kids, like stuffy noses and like adults with fractured things who just need to be set and they go. And we had this kid that came in with their mom and their older sibling for like, they fell down a flight of steps. And the mom was like, oh, they whacked their head pretty good on the steps. But the kid was like playing, they look fine. But something about it, like, okay, the story's like, whatever. But my preceptor taught me like everything is the worst thing ever until it's not. So even the people like always look for the things that are like the worst thing first. And if it's not, it's great. But low priority patients can sometimes be the sickest person in the ED. And I learned that day.
Yeah. I mean, that is a great wisdom for your preceptor. It's always the worst case scenario until proven otherwise.
Yes.
All right. So the kid, how did they look whenever you looked at them?
So when they first came in, they were playing like appropriately and they looked pretty good. They had what rose my suspicion right away was like this kid had a knot on his head. I was so new as a nurse. So I was like, okay, I don't know if this is normal or not. Like, I don't know anything yet. But like I was a preschool teacher before nursing school. So I was like, okay, I've seen kids fall down, go boom all the time. And like this kid's completely normal acting, but like, why do they have a knot on their head? So like that made me think like, is this fall worse than like, they're downplaying this fall, but like, was it actually worse? And they're just like downplaying because it didn't seem like it was that bad when it happened.
Gotcha. All right. So the kid's playing. They're making eye contact. How old is the child just approximately?
I think 36 months because they were able to walk and like a little bit of walking and like their parents were like walking them up the steps. So They weren't like older than 3, but they were in like that 1.5 to like 2.5 range.
Okay. Gotcha. All right. So the kids making eye contact, big old goose egg on their head. All right. So what did you do with this spidey sense that you had?
So I talked to our provider and our provider was very much like, oh, it's not a big deal. Kids fall. But at that time, like when I had said something when they first came in, I was like, hey, do you see that like knot on their head? And it was like, oh, that happens. That happens. So he's out there seeing other people. And about like 35, 40 minutes later, I'm like, this kid is like playing less. They weren't as interested in playing with their siblings as they were when they first came in. He was definitely like not as interactive with like me when I came in the room. Like, think of like the happiest baby you've ever seen that's like happy to see anybody. And then it's kind of like disinterested when people are coming in the room.
So a little altered mental status. All right. What followed after that?
So after that, I had then elevated those concerns back to a provider who was still seeing other people. And I said, look, I know that I'm new. I know that I don't know everything yet. But I was like, I feel like this kid's fall was worse than we thought. And I know that the story is just fell down a flight of steps. But then I started thinking, let me ask more about where the steps were. They were outside when he fell, and he fell down 4 to 5 concrete steps on their front porch. And they're Baltimore City steps. So like a normal step is like 1 is essentially like your normal inside step is like 2 outside in the city in Baltimore City. So knowing that, I was like, that kind of changes like what I was originally thinking. And even the provider, he was like, oh, that's a significant fall for this like little person, this child. So with that, I started asking more questions. And it was really challenging because you have a kid that's sitting there that can't tell you how they feel because they're so young. But I started asking the mom, I was like, well, you saw it happen. Like, how did they land? Where did they land? What did they look like? What did he look like when he got up? Did he cry? Did he not? And I started like really relying on like my nursing assessment to kind of guide what the next like things I was going to go to the provider with. So when I went with the steps and with the change in like attention levels, then it was very clear that like maybe this kid was worse off than we thought. And then we had to put an IV in, and I had been an EMT and I was ready for a fight. And I got no fight at all. No wiggles, no squirms, no like, I don't like it.
Ooh.
And I literally turned, I said, I put in the IV, but this kid needs to go to head CT like yesterday. Like if there's not a stroke back there or somebody who's like about to die, like we need to clear off everybody because this kid like needs to go.
Yeah. I just want to pause and accentuate that because that's really important.
Yes.
For adult patients, we're like, yay, they're such a nice patient, so compliant.
Yeah.
We do not want to see super compliant 3-year-olds. Like they're supposed to fight back. And when they don't, your spidey senses should be like, alarm, emergency, right? That's super concerning. So great point.
And even for me being like a baby nurse and like at the time, like it's so weird being able to like retrospectively think of it now. But at the time I was like, this is so bad. Like my eyes were wide and like, I was like, this is so bad. Like, and I was ready, like if my provider wasn't going to move on that, I was ready to escalate to like the charge nurse and talk to like the other attending on the adult side. And I was like, somebody's going to have to see this baby because I was like, I can't yet articulate what I think is wrong, but something is wrong with this kid.
Right. It's like, all I got is a goose egg, guys, but my gut says it's more than just that. Good. All right. So you push for the CT. They got the CT. And what did it show?
The CT showed a basilar skull fracture, but he also did not fight the CT, did not move in the CT. And that was, again, I was like, oh my goodness was already firing before we went to CT. And after it got worse, this child started to get more drowsy. And then we started to see like the telltale signs of basilar skull fractures.
All right. So that's perfect lead in. What are the telltale signs of basilar skull fracture?
It's Battles and raccoon sign. So raccoons is the ecchymosis around the eyes. Battle sign is the bruising on the mastoid process, which is like the back of the head, where usually around the spot where the injury occurred. They're not super clinically reliable. Like the worse the head trauma, the faster they show. But with this child, this was by the time the CT read came back and we started to see B signs and symptoms, I think maybe 4 or 5 hours had passed. So, usually like basilar skull fractures, it's a fast, quick, like arterial bleed. But for this child, it was just because babies have large heads. And I know that they were young enough that their sutures were not all the way fused yet. because that's the difference in like the how this was not so devastating to begin with, and we missed signs and symptoms. Again, all things I learned after the fact, not in it.
Of course. But you will never forget them now, right? A great case study for what you're learning in the classroom setting. So, Casey, before we go a little bit deeper into the symptoms, can you just back us up and describe what is a basilar skull fracture? Like what's happening inside the skull? And then from that, what are all the possible symptoms we can anticipate or look for if a patient has sustained a basilar skull fracture?
So a basilar skull fracture is any type of break to the base of the skull. Usually it's like a fractured bone in the skull. Usually that's the occipital bone. It can be any of them, but the most common area is the occipital bone. And with that, it causes varying on where it's located with the signs and symptoms, but the most common signs and symptoms early are the change in mental status. You have cranial nerve damage, so a lot of issues with balance. That is hard to see in pediatric patients because if they are walking
or wobbly,
they are already wobbly. They are Weeble
right.
wobbles that sometimes fall down. And then also battle sign, which is the ecchymosis towards the base of the skull, and raccoon eyes, which is from the ecchymosis around the orbitals of the eyes. And usually if you have a frontal bone break, you can also do things like the frontal bone and the sphenoid bone, which are the front of your head and the middle of the skull. That also can distort your sense of smell, which is cranial nerve 1. So it's kind of like a lot of the neuro symptoms. The most common are the change in mental status. So lethargic, seizures are common, balance issues like gait abnormality. And then your later signs are battle sign, raccoon eyes. And sometimes you get halo sign, which is where either have drainage of CSF fluid because of the break and the pressure that the break puts on the brain. You either have drainage of CSF from your nose or from your ears. You don't put anything in their ears to stop the CSF from leaking or their nose. But if you were to put a tissue to it, then you would see a ring of blood on the inside and the CSF on the outside. You can also test it. You can do a glucose test to determine if it's CSF or just drainage.
Yeah, I've seen times when we see little drainage on the pillowcase. And so I'm stare at the pillowcase pattern, it's artwork or something okay, is there halo sign there? And halo sign, just to be clear, is whenever there's concentric rings of the ring of blood and the ring of CSF, they kind of separate out once they hit a tissue or a pillowcase or whatever that you're using to test it on.
It's almost like a bullseye, appearance. When you do see it, you kind of see it and you're like, okay, that's halo sign.
If you don't know what we're talking about, just Google it, guys. I'm sure there's other pictures on the internet of what halo sign is. All right, so otorrhea, rhinorrhea, any other symptoms that we should be on the lookout for if someone has sustained a head injury?
I think the big one is change in mental status. That's really the big thing. That's one of the first signs and symptoms. So, if you're thinking about kids, play is their work. So they go from play to not playing, not interacting. And I think it's important to note the differences based on age. So if you have a baby, an infant, a neonate that has head trauma, if they have altered mental status, it's not going to be the same as an adult. So they're usually not interested in what's going around in the surroundings. So if they were tracking people in the room before, their little eyes were going everywhere, they look at you when you come in the room. When you're doing things with them, they're following you around the room. Altered mental status in them is that they stop doing those things. They're not tracking you anymore. An older kid, preschool age child, would be more likely to not be interested in play anymore and want to do things school age, and preschoolers usually regress and they'll want to sit with their parents. And, they start to regress into that. They want to lay on them or be in a lap versus when they're, rambunctious or running around the hallway and you have to tell them to slow down, they're sick, stop. And an adolescent would present more like an adult, but it's things if you ask them what they did at school or what grade they're in, what classes they're taking, they may not be able to answer those things. Severe head injury, they wouldn't know who their parents are, but a lot of times For adolescents, it's really subtle, and they're just confused on like either what happened that day, or they are sometimes confused about if you ask them like what their life schedule is. Like if you ask them who their best friend is, they have to think about that for a long period of time versus just being able to rifle it off.
Good. That's good tips. Thank you, Casey. So a lot of basilar skull fractures are associated with child abuse. Are there any defining characteristics or things about the history that might point a healthcare provider to investigate a little bit further into the possibility of child abuse being the source?
Yeah, especially with younger children, you might see like the typical signs of abuse. So bruises in various stages of healing, a lot of emergency department visits, the story doesn't match. So for this case too, when you look at the injury pattern and like the atypical presentation kind of went with what they said happened, they brought the child in right away. There were no other signs of abuse. There weren't bruises in various stages of healing. Child well fed and well dressed is another one. That can be a sign of neglect too. So you remember, just for knowing like when patients come into the emergency department, that neglect is a form of like abuse, of child abuse. Looking at the older children, they didn't have any signs of like bruises in various stages of healing. And it's usually the big things where like the story doesn't match what happened. They have other like bruises, slips, trips, falls, a lot of other emergency department visits. Like kids are clumsy, but they're not like clumsy to the point that they're going to the ER multiple times. Broken fingers, broken toes, things that they're coming to the emergency department for. Super athletic kids might come to the ED for a sprained knee or something. But if they're not involved in any activities, then that would be kind of like a sign as well, could be a sign.
For this little one, you got the diagnosis of the basilar skull fracture. Then what do you do with this kiddo?
So for this child, it's like the diagnosis was made. And in the back of my mind, I started thinking about that, but I had never seen a basilar skull fracture in a pediatric patient. All of a sudden, like the sweet baby nurse on the unit had the sickest patient in the emergency department. They got started on 3% saline, and that the treatment was going to be decreasing intracranial pressure and really just keeping this kid stable, making sure that you're watching for like airway changes and things and being proactive and not reactive to them, any changes. So your assessment is like even tighter than it was when you first like saw this child. So just coordinating everybody together. The child went to our regional like pediatric trauma center.
So if you could summarize the nurse's priorities in caring for someone who has either potentially or a diagnosed basilar skull fracture, what's the nurse's priorities for that patient population?
So the priority is to decrease intracranial pressure, and like the quick treatment and identification of a basilar skull fracture is like key. So using your assessment to get the head CT, but also to make sure that we're decreasing intracranial pressure, even if you don't have a monitor to monitor ICP. A lot of it is anticipation and, getting them set for surgery, making sure that you're watching their vital signs. You can keep the room dark, decrease the sound. We actually moved this child to a room with the door closed so that it wasn't like all the loudness and chaos that just inherently is the emergency department. Keeping a calm environment, making sure that the parents too have resources, making sure that you're still checking and calculating safe doses. So you're like advocating for your patient that way and making sure that they're not getting too much medication or not enough for what they need it for. But especially if you work in a mixed unit, because it is not all the time that people have pediatric patients.
That's good. Thank you, Casey. So I feel like this case is just such a good example of how important it is to trust that nursing intuition. Like you were still young in the sense of like in your career. You didn't have all like the data points to be able to clearly like point towards and say, they have this, they have this, they have this. We should be concerned. Just your gut said, this is not right. So trust intuition. And then you spoke up and advocated and got the patient what they needed. I mean, props to you, my friend. Strong work here for this kiddo. And for everyone that's listening, if you have pediatric patients and they're not fighting you, you should let somebody know. That is concerning. They should be not excited about getting an IV, not excited about any intervention that's not, provided by their parents. Like, they should be fighting. So yeah, great, Casey. Thank you for sharing that. Are there any other closing thoughts or takeaways that you would want a nurse to glean from this scenario?
Really, it's just to trust your gut. And like, even if other people are telling you that, oh, it's not a concern right now, if you still feel that, push that. Because for me, this was the first time that I pushed that, and it continued in my career. It's continued now. And now that I have 9 years of experience, I say things and people trust that I know what I'm doing. But when I was new, I found myself having to advocate for my gut. It's just as much as the patient. And even if you don't have any data, I will tell you that if you tell a physician ever, and I just have a bad feeling, even as a new nurse, even if you're not right, you'll be really surprised to find how many doctors, even when you're new, if your gut is telling you something's off, and the smallest thing could be the reason. But if you tell somebody, like, this is my gut feeling, they'll say, okay, let's go with the gut then. And even as a new grad, your gut is your intuition, but that's also like your clinical decision making. And you just don't know that yet when you're like new, because you think a mile a minute in your head, and you don't have all the pieces together, but that's your clinical judgment, like, speaking to you in the form of like trusting your gut and your intuition. So just go with it and continue to like culture that in your career.
Yes.
It's not indigestion.
Amen, Casey. I love it. Well, thank you so much for my podcast. Before I let you go, I wanted the people who listen to my podcast to know where they could find you if they wanted to learn more about Casey or to follow you on Instagram, or how do people find you?
So the best way is through Instagram. It's Critical Care Casey. I'm also on LinkedIn, but like for tips in the profession. But if you want to do like study questions with me, or you have questions that you want like questions about, you want more study tips or things, or you're looking to like meet and chat. Also, if you're looking for a topic that you want covered, I just became one of the section editors for the Journal of Emergency Medicine for the Emerging Professionals Corner. So, yes. So if you have any suggestions for things we should cover, or, you're looking for that, just know that we've heard you and it is coming.
Awesome. Casey, thank you so much for being on my podcast. It was a pleasure unpacking this case with you, learning about your nursing career. I'm excited to share this podcast with my listeners. Thank you so much.
Thank you for having me.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.